I am Fausto Castagnetti, a hematologist from the University of Bologna. My presentation will focus on advanced CML phase, definition to use, and the role of allograft, of allogeneic bone marrow transplantation. We have many historical definitions of CML blast phase. We have a definition from International Blood and Bone Marrow Transplant Registry, MD Anderson Cancer Center, European Leukemia Net, or WHO. There were important differences in the minimum percentage of blast required to define the blast phase. It was 30% in the MD Anderson and ELN definitions, and it was only 20% in the WHO definition. An accelerated phase has been defined as a lower percentage of blast, more than 15% in MD Anderson Cancer Center and ELN definition, and more than 10% in the WHO definition. This point is extremely relevant when we look at the historical data, when we look at published study, to compare results with new strategies. So it is very important to know that the difference have changed over time. In the last definition of WHO classification, important change have been proposed. In particular, the new version of this classification removed accelerated phase CML, stratifying patients into chronic and blast phases only. We consider a blast phase when the blast percentage is higher than 20%. Why this change has been proposed? Because a patient in accelerated phase, according to previous definition, had a very good survival with tyrosine kinase inhibitors, and they have very low incidence of progression. So the prognosis of this patient was very good. So they can be compared to chronic phase patient according to treatment strategy and outcome. Probably other factors like the presence of ABL kinase mutation, the presence of cytogenetic abnormalities, and a greater proportion of blast are these factors able to predict a poor outcome of CML patient. So the new criteria of WHO classification include as criteria to define a blast phase, a percentage higher than 20% of myeloid blast in the blood or in bone marrow of CML patients, or the presence of an extramedullary proliferation of blast, or the presence of increased lymphoblast in peripheral blood or in the bone marrow. However, these new criteria of WHO classification have not shared by the scientific community. And in particular, I would like to underline that the new international consensus classification maintained the accelerated phase of CML. So probably we can consider the classification of advanced accelerated phase CML as a work in progress. What about the incidence of blast phase CML? If we consider de novo patients, so patients with a new diagnosis of CML, only a small proportion of patients has a diagnosis in blast phase, approximately 2% of patients. If we consider patient progressing to advanced phase while on treatment, once again, the percentage of patients with progression to accelerated or blast phase is very low, 3% at 2 years, according to the Swedish registry. So CML blast phase is a very rare situation. Second generation TKI showed higher efficacy compared to imatinib in the setting of advanced phase patient, and the probability to have a progression to advanced phase is very low when we use second generation TKI first line if compared to imatinib. Overall, 1% of patients progress to advanced phase on nilotinib compared to 50% of patients progressing to advanced phase on imatinib. And similar results were observed with dasatinib first line. So the probability to have a progression to advanced phase is very low when we use second-generation TKI in the first line of treatment. How to treat patient with blast phase, with primary blast phase or with secondary blast phase after progression from a previous chronic phase? We can consider a different strategy. Probably the most simple strategy is the use of tyrosine kinase inhibitors as monotherapy. So imatinib or dasatinib or nilotinib. We have also data on bosutinib and ponatinib, mostly in the second or in the third line of treatment. The probability to achieve a complete cytogenetic response on TKI alone, however, is very low if compared to results in the chronic phase. We have 70 to 35% of patients achieving a CCYR. Probably we have higher rates of response with second-generation TKI, but however, in general, the response rate were low. So we try to combine conventional chemotherapy to tyrosine kinase inhibitors to improve the response rate in terms of complete cytogenetic response and measure molecular response. However, the results were not satisfying, but probably we are able to induce higher response rate with the combination of conventional chemotherapy to TKI alone, to TKI, but with the higher toxicity for our patient. So probably if we have a patient in blast phase, if the patient is able to tolerate the combination of TKI and conventional chemotherapy, we should prefer the strategy to the use of TKI alone. It is very important to describe the immunophenotype of blast cells in patients who progress to blast phase. We may have patients with lymphoid phenotype and patients with myeloid phenotype. It is very important to underline that the molecular abnormalities and also cytogenetic abnormalities are different according to the phenotype of blast crisis. We have specific mutations that have been described in lymphoid blast phase and a specific mutation that have been described in myeloid blast phase. So it is very important from a biological point of view, but also from a therapeutic point of view. It is very important to characterize the blast cells after a progression of CML2 advanced phases. In general, the response rate in myeloid blast phase appear to be inferior if compared to lymphoid blast phase. But in general, the overall survival was not satisfying. So how to treat a patient with advanced phase CML? If we have an accelerated phase, according to previous definition, if we have a de novo accelerated phase, we should prefer second-generation TKI as frontline therapy. And if the patient is able to achieve an optimal response, it is not necessary to go to an allogeneic bone marrow transplantation. If the patient has not an optimal response, we should assess for ABL mutation, KD mutations, and we should switch the patient to a third-generation TKI. And probably that patient could be candidate to an allogeneic bone marrow transplantation. If the patient has a secondary accelerated phase, so he progressed to accelerated phase after a diagnosis in chronic phase, well, this patient should be treated with ponatinib if possible, and we should, or with ponatinib with the combination of conventional chemotherapy. That can be chosen according the phenotype of blast cells, and we should candidate that patient to allogeneic bone marrow transplantation. If we have a patient in blast phase with myeloid phenotype or with the lymphoid immunophenotype, we should consider the combination of conventional chemotherapy with TKI, and in any case, we should candidate the patient to an allogeneic bone marrow transplantation. So it is very important to include allogeneic bone marrow transplantation in the treatment strategy of patients with blast phase or with secondary accelerated phase. This indication that the suggestion that I presented have been published by the MD Anderson Cancer Center, and they are shared with recommendation of ELN and CCN guidelines. In general, if we have a patient presenting in accelerated phase, we should prefer second generation TKI. If we have a patient progressing to accelerated phase, we should consider allogeneic bone marrow transplantation. And if we have a patient in blast phase, we should transplant our patient. So almost all international guideline recommendation found an agreement on this indication to allogeneic bone marrow transplantation. It is very important to underline that the probability to receive an allogeneic bone marrow transplantation in the chronic phase decreased over time, because only patients who are resistant to at least 2 tyrosine kinase inhibitors now may receive an allogeneic bone marrow transplantation, and the number of patients receiving an allogeneic bone marrow transplantation for CML in advanced phase did not change, because the indication has been maintained. What about transplant modality in patient with advanced phase CML? Probably we should prefer a related HLA identical donor to other donors, to unrelated HLA identical, but also to other donors, for example, haploidentical donors. What about the conditioning? If possible, we should prefer myeloablative conditioning regimen over reduced intensity regimens. It is very difficult to demonstrate on an evidence-based criteria the superiority of myeloablative over reduced intensity conditioning in CML in advanced phase, because we have very few data, but all panels recommend the use of myeloablative conditioning whenever possible. However, it is very important to underline that in advanced phase, the outcome depends mainly on disease status. If we have a patient with blast phase in remission, it is possible to achieve a long-lasting remission of the disease. If we have a patient with active disease, it is very difficult to achieve leukemia-free survival, in general, a remission of our leukemia. So probably there is no indication to transplant a patient with CML in blast phase with active disease. So in conclusion, the definition of blast phase is controversial because we have many criteria that have been proposed over time. The last version of WHO classification proposed to remove the accelerated phase of CML, considering patient in blast phase when the blast percentage is higher than 20%. Patient with blast phase at diagnosis and patient with progression to blast phase or with progression to accelerated phase are uncommon. In general, the use of second-generation TKI in intermediate and in high-risk patient may protect the patient from progression to advanced phase of the disease. No specific inhibitors or chemotherapy regimen can be suggested because we have few studies that are heterogeneous and not controlled. However, probably a potential benefit of chemotherapy in combination to TKI has been demonstrated, been reported. So in general, the panels of experts recommend the use of combination therapy whenever possible. Transplant is recommended in all blast phase patients, de novo or after progression on treatment, while on treatment. It is very important that the allogeneic bone marrow transplantation should be performed after return to chronic phase. The use of an allogeneic bone marrow transplantation is also recommended in patient progressing to accelerated phase during treatment. A chemo-free approach is a promising strategy as a bridge to transplant, but we have only preliminary data. Probably immunotherapy and new agents may be useful in this setting, but we have not enough data to recommend specific strategies. So at the moment, whenever possible, the use of combination therapy should be preferred. I thank you very much for attention, and if any question, this is my email. I can provide an answer to any type of question or curiosity. Thank you very much.